So welcome everyone. I'm Reed Kaiser with Kaiser Healthcare Solutions. I see very many familiar names. I'd say faces, but it's just Jessica and I that are on video here today. So thank you for joining us. And yeah, I'm excited to kick off today's discussion and have our special guest here with us. So before we dive in, just to kind of make this fun, and somehow we got into the sports analogies of things in basketball, and I know we're kind of at the end of the NBA season here, but we took a little bit of a basketball slant to this. And I've always loved coaching and playing sports. And I recently retired from coaching my kids' basketball teams. They're now growing up and daughters in high school. And just kind of the other thing too, is we were preparing and going back to, some of the beginnings of Kaiser Healthcare Solutions and just going back to me and kind of my makeup and enjoying coaching. But my first dip into entrepreneurialism was starting a triathlon and coaching, cycling coaching business with several of my other friends back in my days when I was really into cycling and Ironman and triathlon. And so one little fun fact about me is claim to fame, if you want to call it that, is I coached Jerome Powell in cycling. You might know his name. He's the guy that sets the interest rates for this country. So that's one of my cool claim to fame is coaching. So yeah, that was fun to do that. But yeah, going back to the basketball analogy. So and coaching. So coaching, really it teaches you to read the whole court. And so Jessica and I and our consultancies, that's really what we're here for is we've played all those positions. We've played for, several different teams, so have a pretty good perspective. And now in our consulting roles, it really allows for us to read the whole court and understand the sport. It's not just the scoreboard or getting to the final buzzer or the finish line. It's as many of you know, it's a in the world that we operate in Medicare Advantage and in quality, it's really a journey with a lot of unplanned challenges that come along the way. And the way that I view a coach, just in general, as well as in the consulting role, is that it helps to keep things in perspective. And we're here to help to adapt to the game plan. A lot of things that we'll talk about while this has been out for a little bit of time here, there's still a lot of uncertainty that's there. But I always say I'm pretty optimistic in when things change. You just need to learn to adapt to the rules and to the game and reset your game plan. So while some things may look like they're going in a direction we may not want, and others are, or we're not clear if they are, it's really about how do you adapt and understand where you need to adapt with that. So, Jessica, I'd love to kind of give you a chance to give a
Well, it's
little.
kind of hard to follow after Jerome Powell, right? Reed dropped that tidbit of information on me the other day, and it was right after that. I don't know what is it, True Social. President Trump put like that, True Social post out about him, and so we were like, "Whoa, you need to say this."
Yeah, yeah.
So thank you, Reed. I'm Jessica Mirator. I am not a coach of sports, at least, but I am a Medicare Stars health policy nerd, as Reed likes to call it, and strategy wonk. And I know we're both excited to be here with all of you today. And this webinar isn't just about highlighting CMS's regulatory updates. It's about what they mean strategically for you, whether you're a health plan or a vendor or a consultant or an investor. I know that both of our consultancies work with all of those parties and then some, right? But you need to know the actual impact of these changes, and so that's what we hope to bring you here today.
Great. Yeah. And then as we get into this, you're going to hear us dish off ideas, insights, and perspectives. And some may be layups, some may be alley-oops, some may be three-pointers, and some may be just some really challenge dynamic, policy things that we're seeing there. But we do want this to be dynamic and useful and fun. So just to kind of keep going on, playing on the pun, let's huddle up and let's tip it off, Jessica.
Sounds great.
Okay, so I know we talked a little bit about our background, so I won't spend too much time here, but a little more formally. For those that aren't familiar with me, been in healthcare quality for over 25 years, starting off at NCQA. I was the data collection manager and the director of HEDIS policy. And then most recently, went to CMS as the director of quality measurement, kind of a little bit of a sabbatical or break within the consultancy, even though Kaiser Healthcare Solutions continued on. And then over those years in between, worked at the largest payer, United Healthcare, and then also the industry-leading quality measure software solutions. So have a lot of experience and perspective, not only in quality measurement, but particularly in the health plan side and the Medicare Advantage side. And as our consultancy, we're now in our 10th year. So we serve health plans. We actually have accreditors that are clients. We serve measure stewards, measure developers, vendors, which can be service providers and technology providers, as well as providers who are on another part of the spectrum for being accountable to quality measures. And really, what we do is, from across from, data collect or data aggregation to data management, but also into the policy side of things and understanding what the policy directions mean for operational capabilities in our value-based world. So that's a lot of what the hat I'll be wearing today is speaking from the policy perspective, and happy to have Jessica because she's really the policy expert here. So Jessica, if you don't mind, just saying a little about yourself and your
Yeah,
consultancy.
absolutely. No, no, Reed, I think you and I complement each other very well. So I'm a healthcare advisor, consultant with deep expertise in regulatory strategy, quality improvement, and managed care. So I work with payers, health plans, vendors, investors, and other consulting firms and help them navigate complex Medicare, Medicaid, marketplace, commercial landscapes, among some others, really translating regulatory challenges into actionable strategies. For over a decade, I did hold some leadership roles at MVP Healthcare. I say that's where I cut my teeth because I was doing everything in the weeds along with my minimal staff, and we really had some fun together. I learned a lot. And then Centene Corporation, where I led national quality market strategy across 38 health plans at that time. I specialize in Medicare star ratings, but I do have a comprehensive understanding of all things Medicare, especially with my utilization management, care management, and appeals grievances background too. Medicaid pay for performance programs, so each state is a bit different with their quality incentive or disincentive programs, and then overall quality operations and programs. And you'll hear Reed and I play off of each other throughout the session. We want to make this feel like a strategy huddle, and so feel free to enter your questions into the chat as they come up, and we'll address them if they're timely or if we know we're not going to be getting to that topic.
Yes, and just on that note too as well. So thank you, Jess, for mentioning. Feel free to put questions in along the way. And just as a reminder, I didn't say this at the start, but there should be a Q&A feature to ask questions. So please put those there. And if somebody doesn't mind just checking your testing to see if make sure that's working, that'd be great. And if we need to fall back to the chat, but please put them in the Q&A. We'll monitor those there as well. Okay. All right. So let's jump in and talk about what changes CMS has made or is committing to for health plans. Or I'm sorry, the overarching themes of I'm reading the wrong thing here. What are the overarching themes of the final rule and final rate announcement and what's impacted? And then the next slide, we'll get into some of those actual specifics. But so looking at and zooming in on the 2026 final rule and rate analysis announcement, what CMS issued in the final rule is more than just a list of those changes. It's a directional shift. It's about elevating accountability, embedding more trust and transparency into the Medicare Advantage program. We know the current administration will be putting more emphasis on policies around Medicare Advantage and health and wellness that is patient-centered and value-driven. Not to say that that wasn't there before, but or in the prior administrations, but just seeing what we're seeing and even going back to, I guess, I can't even remember the number, Trump 43, whatever it was, 2 times ago in SEMA Verma. So a lot of things kind of continue to pick back up there. And I'm happy to kind of share my perspectives when I came in at the beginning of that transition under Biden, but obviously left before the most recent one. But happy to share kind of what I saw there at the time and kind of the things I'm hearing to this day. And so, Jessica, if you don't mind kind of adding as well there.
Yeah, no, absolutely. And we'll stick with the sports analogies. So CMS isn't just tweaking the playbook, right? They're sending signals about where the game is headed. So in terms of overarching themes for both, the release of final rule and final rate announcement last month, it's clear that CMS via Dr. Oz is attempting to balance between supporting Medicare Advantage health plans, their profits, and the public and congressional scrutiny of those health plans, which is no easy feat, right? Reed, you have inside information on that, right? So these regulations, especially those of us who work in the stars world and Medicare Advantage world, their first glimpse into how the new administration is committed to this sort of balancing act. While health plans are receiving a significant revenue bump, in fact, it's a historically high effective rate, it is clear that CMS is positioning the industry for these larger structural changes to come. We know that the V28 risk model will now phase in at 100% for 2026. So that is for sure. That is, something that the health plans lobbied heavily against. And that is, going to help, according to CMS, I think the coding process is more complete and accurate for chronic conditions, and then remove some of those frequently gamed medical codes from the risk adjustment model. This administration has doubled down on DSNP integration and alignment. We're going to talk about that in just a little bit, but they also finalized major provisions of the Inflation Reduction Act, or the IRA, around prescription drug costs and vaccine cost sharing requirements. And that's going to continue to put pressure on Part D plans. And then we saw the Make America Healthy Again, the MAHA agenda, is going to impact those SSBCI benefits as of January 1st, 2026. So less than a year, with the elimination of non-healthy food. And we saw a handful of patient and provider protections, including closing some loopholes in relation to appeals, and then restricting a health plan's ability to reopen and modify a previously approved inpatient admission. So, Reed, I think overall, the finalization of the 2026 final rule and final rate announcement show that this new administration's continued support for Medicare Advantage is there, even after removing provisions that they don't feel aligned with their new priorities.
Yeah, and I think, they're keeping it flexible on purpose, and it's somewhat of a, I hate to say, watch and wait lever that's there. But we know, and the plans need to move now, not react later. And, once again, it will be a physical game, so to speak, in basketball analogies, as we get through, what we've gone through, I guess, the first 100 days of this administration, and, what may or may not be coming ahead of us. So,
Yeah.
great points there. All right, so here's where I wanted to start off with, but this is around the changes that were made to health equity. And I know when this first came out, believe me, I was getting a lot of text messages, emails, phone calls, like, what's going on here? Why are they stripping out health equity? So I'd say this is probably one of the most talked about features in the final rule. And I always get kind of turned around. It's excellent health outcomes for all. It's an interesting acronym. I'll hold my opinions on it. I'm sure everyone's got theirs too, as well. But yeah, that's really a long acronym there. But really, this is about the making this more, and this is some of the things, like even internally when I was at CMS, and when we first were coming out with being more front forward with the use of the terms health equity. There was also, and this goes back to Seema Verma, where she was very adamant about rural health, and health equity can mean a lot. There's a lot of different situations, perspectives, or, demographics or populations. But really part of this is like the internal speaking. We were viewing things like, we're looking for making sure everybody's getting the best outcomes that are possible. And obviously there are the areas where there are, whether it's access or financial or health literacy or other factors that are there. I don't see, and we haven't seen this yet with the Health Equity Index, and I'm surprised it wasn't renamed as well, and some of the rules that have come out. But really, it's the reward. This EHO for all is the reward that's replacing what was, I think, somewhat, a name changing of the health equity or health equity index and moving forward. And so CMS is moving from identifying those disparities to more actively rewarding performance and achieving better outcomes across populations. As Jessica mentioned, a lot of focus coming from Dr. Oz around health and wellness. And I know there is, well, I don't know if it's debate, but chatter that, is that CMS's job or position to drive the policy on health and wellness. But, I think plainly speaking, it's moving that forward to looking at things from, more upfront prevention, health and wellness perspective, and then tying that in with, making sure that it's addressing health equity for all, or plainly what I'm still going to call health equity. And so, yeah, so Medicare Star leaders and other analytic vendors, they were anxiously really waiting to see what would come out and what this rebranding for all means. And, it's kind of interesting, some of the little nuances that you see in the language, like social risk factors are now just called factors. I guess if one was looking at it from a pure research perspective, and trying to figure out where a root cause is, you're looking at all the variables or factors, but, somewhat of just, somewhat of a name changing there. We haven't seen anything super significant in what those factors are. I mean, maybe more to come there. But that's where I go back to like some of the insights that I have just when working there, 2 years ago or so. It really was about looking at, okay, what are all these factors that we need to understand, each, whether it's a health condition, whether it's a facility type, or it's a population, as I'll call it, or cohort, is really looking at what are those different things that are driving lower outcomes or less optimal outcomes. And so, other things I think we'll start seeing more around the benefit design. This is some of the conversations that I've been having with just, folks at CMS and kind of where they see or what they're, quote, hearing there is that I'm thinking that, there's going to be probably more that's really getting into what is it that Medicare Advantage plans are doing around benefit design and tailoring that back to those things that we talked about with health and wellness. And yeah, like we said, is it really CMS's role to drive health and wellness? But I guess if we're looking at it from a comprehensive care coordination type of perspective, that does fit into it. And it's always been there, right? With Medicare Advantage, and we saw a lot of gains that were made, and frankly, a lot of, there's more beneficiaries now that are MA, and there's some pretty good benefits that were starting to come into through those Medicare Advantage plans. So is it a newer change? I mean, yes and no, but definitely there's going to be more, more that we're going to hear and see that are going to be under that health and wellness type of language that's used. So, the rules change, and just or maybe sometimes the definitions or the words change, but that's where, once again, kind of going back, is like we try to, we determine what those are and we adjust our playbooks, and if we need to sharpen or develop new skills, we do that.
Yeah, I agree, Reed. And it's also really great to hear perspectives from the inside, if you will, right? Just see what the conversation is. I remember uh December 12th, 2022, I was at Rise Masterclass in San Diego when this proposed rule dropped. And I remember just sitting there on my phone reading, which is probably the reasons I have glasses now, but reading through and thinking like, wow, like what's happening? And I remember somebody that I was with making a comment like, is this April Fool's? When we saw like reward factor was going away and this health equity index is coming in, and like, wow, like what does this mean? What is the impact to the industry? And here we are, fast forward, 2.5 years later. And I think that when this final rule and final rate announcement came out, most everyone who works in stars was skimming through first to see what was going to happen to the health equity index, right? And I think to most people's surprise, the health equity index was, kept in place, but now rebranded this excellent health outcomes for all, or EHO for all, which has become quite a famous meme on LinkedIn, rightfully so. Trying to say EHO for all versus HEI was just, it's a hard transition. And CMS said that, this is why they made this naming change. This is going to better capture the goal of ensuring exceptional care for all enrollees, which I find a little funny because they confirmed all methodology for HEI stays the same, or EHO for all, at least for now. But then they said they may consider additional changes through future rulemaking, which we knew was going to be coming anyway. But we're saying it's EHO for all, but we're only focused on certain populations right now, right? So CMS did know that we may see this rural urban geography factor added to the EHO for all, that they had mixed support and they'd have to define things clearly. I do think that's coming. That is definitely going to come down the pipeline sooner than later. And as you mentioned too, one of the things that stuck out for me is, the prior administration referred to disabled LIS and dually eligible populations as having these social risk factors. But then throughout the minimal amount that was addressed on the health equity index, there was no reference to SRFs whatsoever. And we got used to this term, right? It was just factors, lowercase f. So social risk factors are gone. We're just calling them factors. So again, I talked to a lot of people, and I know a lot of people that thought that HEI was on the chopping block altogether. So now, like, if I'm a health plan or if I'm a vendor that can have impact here, or just like even as a consultant or advisor, I am doubling down on those, dually eligible, the LIS and disabled populations. And I'm going to focus on measures that are close to the cusp of the next tier. So the way that the health equity index or the EHO for all works, at least as of now, is you have these three tertiles, these tiers, and moving the bottom third to the middle and the middle to the top. And if you improve from the bottom to the middle tertile, it improves your reward the same amount as if you moved a measure from the middle to the top. So keep that in mind strategically, because it doesn't necessarily mean you have to move all of your measures into like the top tier, right? Don't forget to watch those measures that are on the cusp of dropping down a tier, looking at all eligible measures with the EHO for all, which are closest to the next tertile threshold, and then drilling down to understand what the actual driver of low performance is going to be critical for a laser focused EHO for all strategy. So what I'm saying, like in summation, Reed, is as of now, HEI is here to stay in its original form, with the exception is they're officially going to be renaming it through rulemaking. If EHO for all, whatever we call it, it still looks and feels the same as of now. And so continuing to double down on those strategies, whether or not you are eligible for the EHO for all reward or not, these are the most vulnerable members that we're serving across the country. And it is important to have different strategies and stratify them out to understand their barriers to accessing care, because the reason that CMS proposed this in the first place is they've seen these extreme healthcare disparities. And so making sure that those members are not lost, even if they're a minimal amount of your population, they need different and additional strategies to access their care and have better health outcomes.
Yeah, Jessica, as you're talking there, it reminded me of just some other insights that kind of came to mind as well. And part of the thing when I was going through the interview process and coming into CMS, and part of my traction that come there was around addressing disparities. And so when I got in there, it was interesting where a lot of the things that were helping to identify those populations and needs were stuff that, I go back to my days at United Healthcare, and this is like at least 15 years ago, where we were doing things that were very innovative around addressing disparities. So when I got to CMS, it was a little bit eye-opening that dual eligibility was the only one thing that we really had in our arsenal at CMS to um, to identify those populations. Even discussions of talking about race, ethnicity, language, and other things where I'm sitting there like we were doing this like 15 years ago at United Healthcare, and so there's a lot of things, and especially like with data and challenges or just availability and where to get that data, because CMS does collect a lot of the demographic information on enrollment, but there's protections or firewalls and how that's then distributed. So that's always like the challenge that's coming there. But you reminded me of that, and just like when I got there, it's like, oh my gosh, we're kind of back to where I was 2005. But hey, you gotta start somewhere. And hey, and
Yeah,
we know how healthcare is. It can be, in policy, can be sometimes 20 years behind.
yeah, yeah,
But really, like the key point is going in using that United example, or my example there is, I think where what we're seeing here is the framework is left open somewhat, where they are looking and putting, somewhat maybe more, whether that's written or read between the lines, is to give innovative plans that opportunity to lead. So thinking of United Healthcare 20 years ago, and doing tailored member outreach based on if they're African American, Asian American, Hispanic, Latino, et cetera, being able to do that. And that's what we were doing, is looking at creative ways in how to stratify that data, and even using things like the marketing firms would use, like magazine subscriptions and all these different things that here's the thing, somebody out there knows a lot about you, and unfortunately it's more than your doctor may know, or your health plan may know. But this is where over time and continuing innovation and hoping to get there within it. So it really is about playing that long game, and that's what I think what CMS and this administration wants to see. Some of the other insights is kind of, we were Jessica and I are going through the final preparations or run through for this, is really like, I'm wondering if we saw OMH was one of the first offices that got doged. I'm wondering if we'll see a new form or a reboot of an office that's around, health equity for all. I don't know if that's a little bit of a reach, but to me, it seems like it might be. And, that one was cut, maybe a lot because it was politically driven with the naming of it. Also, I think CMMI models too. I think we'll see a fair amount that's coming out of that, and I think it'll have to be if we're starting to, or I should say, if Dr. Oz is, kind of stretching the things into some of these other areas that are really true, health and wellness versus care management, or processing claims, or making sure people have access. And it does, and I've always said this, it does become geographical. So maybe we'll see some more that comes around that. And yeah, and I don't know, Jessica, if there's any additional points for me, the next one on, maybe we'll see something, later in the year or through other communication channels or others. But I'm not sure if there's any additional insights or thoughts you have just on, you know,
yeah. No, I mean, I did chuckle when like the health equity index first came out too, because for Medicare, this was like, oh my gosh, we're losing reward factor, and now we have to like focus on health equity. But like, I came from the Medicaid side of things, coming from like one of the largest payers in the country that insured Medicaid members, and some of the most vulnerable populations. And in health equity, it wasn't named that back then, but like um, health equity was something that we were addressing consistently. I mean, for over 10 years. So it's like you said, the healthcare industry as a whole is behind the times, especially from a technology perspective. But it's funny when I compare and contrast like Medicaid and Medicare, just seeing what's been happening in the different product lines, and kind of how it diverges, and how regulation really is driving a lot of our behaviors and what we focus on, and not necessarily doing like what's right for the member.
Yep. Yep, absolutely. And I won't get into free markets versus regulated
Yeah,
markets,
yeah,
but
yeah.
But yeah, I mean, the reality is sometimes the private or free market is looking to the government to help give that direction. But yeah, all right. All right. So let's go to some of what the changes were. So let's talk about these changes and more try to provide some more insight on what these mean or what they may not mean, or may mean even longer down the road. Like we talked about before, it's a journey, it's the long game. One example around breast cancer screening measure. I can talk a little bit about this in general, just around measures in those populations. But you see the expanded age cohort, whereas the guidelines have changed and gone down to 40 years of age. We also see the movement to, well, with this particular HEDIS measure, to an ECDS format of the measures. So, we may start seeing, and I think also with, and I'm speaking kind of like if I'm inside and I've got my CMS hat on, if I'm looking for ways to expand policy beyond the Medicare population, it's things like this that can allow for that. And one of the things that I'll say I liked is when it's CMS is, it's great that you're there and you have, the one of the largest population of patients or beneficiaries that are out there, and you're focused on those that are 65 years and older, or dual eligible, or maybe some cases Medicaid, is when there's an opportunity to have a measure that went broader than just Medicare and that specific cohort. By all means, that got an extra point on my score sheet, and especially like it was an all payer one where it wasn't just Medicare. It's like you're going to report a rate, whether it's for commercial, Medicare, or Medicaid. And so I think this is one thing, whether that's intended or not, I will say, and why it looks like, and sure, there's going to be the questions like, well, if I'm truly a Medicare focused plan, what do the 40 to 64-year-olds have to do with it? And I think that just goes down to why we're in quality in the first place. It's like, yeah, we should be doing everything. It shouldn't be different. And I hear this a lot from our clients where, as you know, we get called in to help with their stars programs. And, you'll hear this. It's in some cases, it's like, say, well, what are you doing different or not doing for your Medicare Advantage population? And they're like, oh, we treat all product lines the same. And it's like, well, that's great, and you should, but if you're literally losing tens of millions of dollars a year because you're not doing the extra focus on a specific population, then you might want to start doing that. But in the general sense of things, that have it's good to look at things regardless of the population, just in general, and doing it that there, and going back to some of the things around the quote factors. If you have factors that are driving it, you want to know it. But like in this case, it really, intended or not, it really is, should be indicative of the overall care that plans are different. Now, it does mean too that the health plans, Medicare Advantage plans, need to adapt their tactics to it, right? So where there might have been the focus on the 65-year-old population, now you need to, if you're not looking at things broadly, it's now you need to start looking at that and understanding what those populations are, because it is kind of a more holistic. And like I said, I think if I'm Dr. Oz and I'm one's trying to figure out how do I promote these policies broader, it's give me more all payer measures and let me, use this, the full or the largest or broadest set of within clinical guidelines population there as well.
Yeah, well, Reed, you addressed one of the biggest direct changes to the star ratings, to a measure, BCS. So, coming up in measurement year 27. So if you're working with this measure, take a look at your 49-year-old population performance. That's an important next step. And to your point, you might not think that you have any 40 to 49-year-old members in your population, and that may be true, but also I've worked with a lot of plans that actually, when the health equity index first came out and CMS first gave their simulation data over, and plans started looking, I had a plan that identified they had a very large disabled population. They didn't even know it.
Mhm.
So their strategy had to be pretty significantly different as a result. So definitely you have some time. Measurement year 27 is when that new measure will take place. So star ratings 29. Take a look at that population, look at their performance for this age range, and see how it's going to impact your overall performance on the BCS measure. Honestly, like these regulations weren't as eventful for star ratings part C and D directly, at least not yet. Final rate announcement made some measurement year 25 changes to align with PQA and exclude contracts with 30 or fewer enrolled members in the denominator. And that was for the med adherence measures, SUPD, and the newbies, COB, and poly ACH. This sounds familiar because we've been using those denominator thresholds on the HEDIS side already, right? But CMS viewed this as a not substantiative change. And we've seen over the past couple of years that they've been aligning with PQA. So again, nothing major, no huge news. If you're a smaller health plan with denominators that carry around those thresholds, take a look at that. That could impact you more significantly than others if you're really performing well on medication adherence, but now maybe you only have 25 members or SUPD or something like that. It could have an impact, a negative impact or a positive impact. CMS really, they came out and stated that they're proposing other policies to amend Part C and D star ratings, but they're not addressing those proposals in this final rule, and they may be addressed in a future final rule. And my mind immediately went to second final rule. Sounds familiar again, because we heard that about 2 years ago. We're still waiting for some of those provisions to be addressed. So whether or not we're going to get a second final rule, time will tell. And I think actually the biggest star ratings Part C and D impact here is indirectly addressed in the final rule, though. And I want to take some time to talk about this, because I haven't really heard anybody talk about this. And what I mean by that is the impact of the member experience. So some of these changes, like closing loopholes in the appeals processes that adversely affect providers and members, restricting a health plan's ability to reopen and modify a previously approved inpatient hospital decision based on information gathered after the original approval, the IRA codification of vaccine and insulin cost sharing, and the M3P program, this DSNP integration and alignment, and the non-healthy food no longer being allowed for the SSBCI members. That's all going to manifest in the member experience and in the member experience star ratings measures. And if you think about these changes in terms of the CAP survey and CTMs, right, complaints and disenrollment and appeals, yeah, we didn't see many specific changes to star ratings measures themselves or the methodology of calculations like we have in the past. However, CAPS is worth 21% of star ratings this year, and those operational measures are worth 17%. That's almost 40% of your star rating performance right there. So health plans, those of you who are working with health plans, alongside of health plans, supporting health plans, you need to understand that these indirect impacts, what they are, and whether or not they're going to act as tailwinds or headwinds for you. And so this is a critical step in building out your star rating strategy that I would focus on. Again, even though we didn't see very many direct changes to star ratings, there's still that content in there that we need to pay attention to.
Yep. And I know you just mentioned DSNPs, and so I'm going to use that to segue into our next section here. And we're doing great on time. So good. But yeah, so DSNPs aren't just a compliance category anymore. As Jessica's kind of talking through and really looking at it through CMS's strategic spotlight. And thinking of some of those things like guidance on integrated ID cards and health risk assessments, member experiences, as Jessica mentioned, shows CMS is serious about the financial integration and the overall experience for the beneficiaries or members that are there. So Jessica, let me ask you this question. So what important takeaways from either the final regs that or the final the final regs, or and what was that impact to DSNPs, if you can kind of go a little bit more on that?
I've spent a lot of time working with DSNP populations in my managed care career, and I said this in another webinar, and I think it's so important that I'm going to reiterate it again. If you're a DSNP plan, or if you have a DSNP plan or a PDP, you need to go into the final rule and read pages, I think it's 270 to 331, right? Like it's ingrained in
Yep.
my brain. I've read it
There's
about
that,
7 times
nerd.
now, right?
There's
There's the
Jessica, the
policy. Yes.
policy nerd coming out.
and
Yep.
and and read it multiple times. And the reason I say this, and anybody that is responsible for decent strategy and stars, there's critical information in there about where the administration is headed with DSNPs, right? And Reed,
Mhm.
you and I have talked about this before. I'm not talking about the codified changes where we saw this posted all over LinkedIn, and it's a summary
Right.
of like what the changes were, right? We know now that DSNPs, specific types of DSNPs, are going the applicable integrated plans. So your FIDEs, your fully integrated health plan, DSNP plans, your HIDEs, your highly integrated, some of them, and some others. They're now requiring an integrated ID card and HRA by January 2027. I'm talking about what I referred to in this last webinar as breadcrumbs that CMS left us in the responses to the public comment. I love reading final rule because of this, right? You get more information from the comments and CMS's responses than actually like the summaries. And all indicators are pointing towards this administration's commitment to DSNP integration and alignment, just like the previous administration. So this is a great thing, right?
Mhm.
But CMS has been taking its cues from the MMP demonstration program, which is coming to an end next year. So like I said, we saw in final rule, we have these integrated ID cards and our HRA requirement, just like with the MMP plans, the demonstration program. But CMS also listed out the states, 11 to 13 of them, it varies, that have various integrated materials. So that could be things like summary of benefits, provider and pharmacy directories, the formulary, the ANOCs, the annual notice of coverage, right? Member handbooks. If I were a health plan with any aligned DSNP members, or if I'm a consultant, or if I'm a vendor that's working with any of these populations and these, aligned populations, and this is an opportunity to be proactive instead of reactive. And you have a playbook available to you in pages 270 through 331. And internally, I'd be talking about how to roll out the integrated versions of these additional materials too. Obviously, you want to prioritize the codified requirements first, right? But it's coming. It's the right thing to do to provide this population with a less confusing, a less burdensome, and a more accessible experience. So if you're a health plan and you're not already in one of these 13 states that requires like the integrated ID cards, say for example, your New York's, your California's, you can go look to see all the states in there. You can request that you should reach out to your state first and highlight the section of the final rule. Request that they start outreaching to CMS about these model materials, because CMS said that this is how you do it. And then you can also outreach to other states and health plans that already have these integrated materials. I was even able to do some, Google searches and whatnot and find some of this material online. But this is really an opportunity for us, again, in the industry to be more proactive for a very vulnerable population and a growing population, right? And by doing this, you're going to see results in your member experience performance and your clinical measure performance and reducing medical spend. And then it will have a positive impact on EHO for all if you're eligible for that reward. But beyond that, just again, this population who needs to be able to access their health benefits in a more efficient and standardized way. So I think like it's a lot to say, like important takeaways from the impact of DSNPs, but I thought this was one of the most important parts of the final rule.
Yeah, no, and I appreciate you pulling that out and bringing kind of your expertise and insights there, because that's I think you're hitting on a lot of key points, and it's really going back to innovation. It's like the smart health plans are plans are going to be going beyond just checking boxes, right? And this is about really operationalizing that person-centered care. And yeah, more around using, real-time data, more complete data, and having that frontline alignment, getting back to not only care coordination, but the member experience in it. And, to use another kind of sports analogy, it's Moneyball, right? It's like you run through
Yeah.
run through the numbers and you figure out like, okay, what's the likelihood, or what's the unlikelihood of something, and what do we need to do to impact that? So. All right, well, I think this is our last little section before we spend some time on Q&A. And so if you missed or noticed things that were missed or missing in the final rule, I know Jessica and I definitely, you're not alone. Many of the boldest proposals didn't make the cut, but that, I think, to Jessica's points, what she's saying earlier, doesn't mean CMS is backing off, and we may see some, further direction that's coming in the year, or in the future, future rule writing phase. So
Yeah, I feel like there was more unaddressed and actually addressed in these regulations. I'm sure that much of this has to do with the new administration coming in, right? And the fact that Dr. Oz was only confirmed like a day before the release of the final rule, and like the weekend passed, and then final rate announcement had to be released on April 7th, right? So if we start with, the topic that's near and dear to my heart was star ratings, part C and D. One of the things that I noticed is for Universal Foundation, although CMS was very clear that they're no longer pursuing that SNSC measure, right? They didn't comment on the adult immunization status, the depression screening and follow-up, and the IET measures, which we were all but sure that they were going to be finalized for rulemaking and moved into the star ratings in the next few years. But the CMS was silent on these. That said, I would not take your eye off of that ball when it comes to these measures. Obviously the administration called out the SNSE measure with their agenda related to kind of like focus on health equity and social determinants of health, and kind of washing that away. But these measures still should be your priority display measures, at least until we learn more about the direction of this administration and star ratings. So please don't take your eye off the ball with those three measures. All the operational and SNP only measures were proposed for retirement. And then April hit, CMS says they're contemplating proposing future changes to these measures, and then that's it. I personally am surprised that CMS didn't remove the call center T2IFL measures. They've been the center of controversy for the past 2 years, with several lawsuits that they have been on the losing end of. And then both 5-star cut points are at 100%. We would still be monitoring these from a compliance perspective, but I still don't understand why they've kept them around for star ratings purposes. And then, their typical CMS said these other proposals may be addressed in a future rule. So again, do we assume final rule? Nothing's guaranteed. We're still holding our breath from the last time we went down this path, but, we'll see. Yep. There was also, read, the anti-obesity medication, the AOM coverage in Part D. This is another thing that CMS didn't finalize. And so that's like the coverage of the GLP-1s like Ozempic and Wegovy. I know that health plans let out a sigh of relief here, because the sustainability of the cost of this alone was huge justification against this proposal, right? Medicare policy change, not to mention the long-term data that just simply isn't there to justify this cost. So I was not surprised at all to see that, especially with this administration and RFK Jr. coming in with the Make America Healthy Again. I was, if I were a gambler, I would have bet that wasn't going to be finalized either. One thing that I was a little bit surprised about that wasn't addressed, just really one sentence really, is the AI and algorithm guardrails. So CMS decided not to codify any guardrails around AI and their algorithms for prior authorization, but this is absolutely inevitable. We will see this regulation. It will be broad sweeping, most likely coming from Congress. So health plans, please, vendors, make sure you have AI governance in place now, establish oversight committees, ensure clear reasoning for approvals and denials and prior authorization side, because that's really what's being targeted from an AI perspective. And some health plans have already gotten into some really big hot water and ethical considerations as to what they're doing. Maintain detailed documentation on your algorithms. If you're using a vendor, make sure you're working with one that's transparent and open to explaining their algorithms, because I know a lot of them are not. And engage with CMS and state regulators on this now to stay informed, to gather information on best practices before AI is more heavily regulated, so it's not as big of a lift for you in the future, because it's coming. You know, I saw a statistic. Someone posted that in Q1 of this year alone, Reed, venture capital, the biggest investment, 71% of venture capital funds went towards AI.
Yep.
Like, that's phenomenal in Q1. You know, it's like its trajectory is straight up, right? So AI is definitely going to we're going to have to get our arms around that. It's going to be regulated. And I think it's most likely going to come from Congress, especially with CMS kind of taking like a kind of a backward, you know, step on just saying, well, you know, it's important and it'll be addressed in the future. And then, you know, I think finally, anything, we kind of talked about this, anything that had health equity or social determinants of health, it's currently under review now, right? The administration came out and said that. And that includes, but isn't limited to, the Health Equity Index, now the EHO for All for star ratings, health equity, UN policies and procedures, the HRA requirements focused on equity and social determinants of health, et cetera. So continued commitment to wipe out anything like DEI related with this administration, and with the speed in which we've seen things happening around these types of topics for this administration, I'm going on a limb and saying, I think we get a second final rule from this administration. It seems to be such a significant priority, and it was said in so many ways in these two regulations. But, you know, Reed, like, what are your thoughts with your experience and your insights from CMS and regulators on that?
Yeah, no, I think it's a good question. And yeah, I definitely think, you know, but looking at a crystal ball, I wouldn't be too
Your magic 8
surprised.
ball, right?
Yeah, there you go. Yeah, with it. And yeah, so it probably not unlikely that there wouldn't be another announcement coming before the end of the year. So Jessica, it's been a pleasure to have you as our courtside analyst here, kind of joining me as the coach. I do see we have some questions
Yeah.
here, and oh, there we go. This is thank you, Jennifer Bitterman, for creating
Uh,
this. Speaking of AI,
yeah.
AI,
So good.
we weren't at the game together, but Jennifer did a great job making it look like that. We didn't. I wanted to have the headphones on, but didn't quite get the time for that. But yeah, looking to take some questions here, and I see one. So borrowing on the basketball analogy. So if healthcare is a basketball game, are we playing to win or just keeping score with our current quality measurement strategies? So I guess that's one question. And the second part of it, and are we running a full court press on health equity, or are we still stuck in a defensive zone strategy? Jessica, you want to take the first stab at one of
Yeah.
those? I'm happy to.
Yeah.
Yeah.
Um, First of all, Jason, hello. Nice to
Yeah.
see you.
Hey, Jay.
Thanks for joining. Um, if healthcare is a basketball game, are we playing to win or just keeping score with our current quality measure strategies? Well, I mean, I think that's up to you, right? Um, Personally, I think strategically, the only thing that we can count on, especially in Medicare Advantage, and its star ratings, is change. We know this, it's inevitable. And with a new administration, even more change. And so playing to win is key here. And playing to win entails understanding, picking up the breadcrumbs CMS is leaving behind, understanding the impact of these regulations, you know, being strategic, using data to drive your decision making, leveraging some of these advanced technologies. I mean, sometimes internally you might have the expertise, but do you have the resources? So having that discussion, build or buy, and leveraging vendors that can do things on your behalf that are more innovative, that can focus all of their attention on different areas and measures to impact your performance. So I really think we need to play to win.
Mhm.
And then in terms of running a full court press on health equity, or are we still stuck in defensive zone strategy? I do think that that again is a decision that's unique to each health plan and to vendors and consultants. My personal preference is a full court press on health equity, whether or not you
Right.
qualify for the reward. These are vulnerable members that are most likely driving your improvement, depending on, the percentage of members driving it down. Though they need different strategies, they have different struggles to accessing the healthcare system. And so I do think you run a full court press on health equity, regardless of what administration is in place, what they're saying is regulated versus not. This is still a strategy that you put in place, and you have to be on the offense with this one.
Yep. Yep. Yeah, and I completely agree on the full court press. And I mean, even looking at the health equity indexes, I mean, they're still based on those specific populations that that we
Yeah.
we're historically looking at under health equity. And just I'll add on to like the quality measurement piece. And I know I mentioned earlier about CMMI. Definitely as more policies moving to value-based care, I think there will start seeing a lot of creative, maybe innovative approaches to measuring some of these policy changes through these different models. So there is some of the, well, to Jessica's point, yeah, we're playing to win. It's more than just, keeping score, keeping the game within reach, but it's playing to win. And I think, one for what measures are on the test, but then also looking at it and being innovative and, working more towards what the future models may bring, specifically coming out of CMMI. All right. Well, we got 2 minutes, so I know we have a couple of other questions. So let's see what we can do here. So let's see what.
I think we're good, Reed. I think
You
it's
think we're
just
good? Okay. All right.
thanks for the comment, Jason. Thanks for the question.
Yeah, that was a really good
Question.
question, Jason.
Mhm.
So multi-pronged there. So you obviously know how to
And
run a basketball,
I was
run
going
a
to say, and
basketball
he
team.
kept up with the analogy. Yeah.
Yeah. So all right. So yeah. So yeah, I think just in closing, well, one, it's been a pleasure, Jessica. I'm glad we've been able to like start to, further develop our relationship over the last few months and getting to know you and working with you as well. And, having you sitting here by my side here on the court as we go through this. And one last thing that I'll mention that just, echoing, one a takeaway, I think, whether well, that Jessica mentioned is, and I'll say this coming from the CMS perspective, going back to those public comments that come in on proposed rules or they come in on the proposed rule and then are addressed in the final rule. I can't say how much you should comment on those.
Yes.
CMS does. I know there's other organizations that take public comments and they've already got their directions set.
Yep.
But CMS takes those very seriously. They have teams of people that go through and literally we review every single one of those and get grouped together. So,
And
one
they have
thing,
to be answered. So,
yes. Yeah,
yeah.
and the answers that come out of it, in some cases they may not give you like the answer you want to hear, or maybe it's
Right.
still kind of a TBD.
Yep.
But that's really to Jessica's point. This I'm not going to give like Jessica's secrets, and she's got a lot more secrets than this, but that's one of the things. Like, if you really want to learn and understand what it is, it's like you may not know it on the proposed rule, but when the final rule, those comments come out, it is a wealth of information, educational, as well as directional that comes out of that. So if there's one takeaway besides all these other things, you know, happy to have more conversations with folks so you know how to reach us. But that would be it. It's like really, look at those public comments and don't be afraid to make public comments.
Thanks for having me, Reed. I appreciate it.
Yeah.
It's great.
Yeah, it's been